All right, we're skipping the small talk today and jumping right into the insidious progression and the catastrophic conversion of age-related macular degeneration. As clinical consultants, we have to recognize this. It's literally the leading cause of non-reversible, permanent, bilateral visual loss in the elderly across industrialized nations. In this explainer, we're going to precisely isolate the mechanisms, pinpoint the key markers, and lock down the discrete management steps you absolutely need for flawless diagnostic precision. Let's get to it.
So let's look at the baseline pathology of the aging eye, focusing strictly on the extracellular accumulation that really drives this disease. Now, you know the macula. It's that central area of the retina doing all the heavy lifting for fine, high-resolution visual acuity. It's what lets you read or drive. But early on in this disease, chronic oxidative stress starts to overwhelm the eye's cellular clearance mechanisms. And listen, this isn't some overnight event. It's a chronic, grueling cellular breakdown that basically sets the stage for everything that follows.
And, that breakdown leaves a very distinct physical footprint. The strict pathological hallmark of non-exudative or dry age-related macular degeneration is the progressive deposition of drusen. These are localized deposits of yellow, extracellular lipoproteinaceous material. Now, you must lock in on their exact anatomic location. They are deposited strictly between Bruch's membrane and the retinal pigment epithelium, or RPE. The sheer presence of drusen is the fundamental physical marker of the dry matrix of this disease.
Just look at the visual evidence here. In a high-contrast retinal cross-section, you can clearly spot the drusen, those scattered yellow subretinal deposits just piling up in the macula. Now, what does this mean for the patient? Well, this dry matrix drives a slow, gradual, and completely painless loss of central vision. Their peripheral and navigational vision? Totally fine, but that precise central acuity just slowly degrades. We call this atrophic AMD, and it makes up roughly 80% of all cases.
So how do we manage this non-exudative phase? The clinical signature, as we just saw, is a slow, progressive, bilateral loss of central visual acuity. And here's the tough reality. There is strictly no curative treatment available. None. Because of that, our intervention is purely prophylactic. We have an absolute mandate to demand smoking cessation, since smoking massively drives that oxidative stress. Pharmacologically, we use antioxidant vitamin supplementation, specifically vitamin C, E, zinc, and lutein, which definitely slows down the disease progression. Just a quick, critical exception to keep in mind. You have to be super cautious giving high-dose beta-carotene or vitamin E to active smokers, right? Because it's linked to an increased mortality rate from lung cancer.
Okay, here's where things get intense. We absolutely must contrast the chronic cellular baseline of dry AMD against the sudden, violent hypoxic surge that characterizes wet or exudative AMD. While the dry matrix is all about that slow extracellular drusen deposition, the wet matrix is driven by severe local tissue hypoxia. This hypoxia acts like a trigger, setting off a massive acute release of vascular endothelial growth factor, or VEGF. And that VEGF? It strictly drives the aggressive proliferation of fragile, abnormal blood vessels shooting up from the choroid.
And the sheer destruction this causes is just alarming. You are looking at a full-blown hemorrhagic catastrophe. Those newly formed superfragile choroidal vessels aggressively leak serous fluid, and they strictly hemorrhage right into the subretinal space. So, unlike the slow, insidious timeline of the dry variant, the clinical signature of exudative AMD is a rapid, acute, and severe loss of central vision happening over just days to weeks. The macula is physically elevated, just absolutely swamped by this exudation.
When this catastrophic conversion happens, time is vision, literally. The absolute immediate medical mandate here is the administration of intravitreal anti-VEGF inhibitors, drugs like ranibizumab or bevacizumab. We aren't talking prophylaxis anymore. This is an aggressive, immediate rescue maneuver, strictly required to halt that neovascularization, stop the active fluid leakage, and prevent permanent fibrous scarring.
So what does this microscopic leakage actually look like to the patient? They experience it as a macroscopic topographic distortion called metamorphsia. This is a strict exam finding, usually picked up with an Amsler grid, where patients will tell you that perfectly straight lines suddenly appear wavy or bent. Why? Because that subretinal fluid is physically elevating the macula and completely distorting the alignment of the photoreceptors. Let me emphasize this. Metamorphsia is an absolute clinical emergency indicating active subretinal fluid leakage.
Let's reinforce our pattern recognition here. If we isolate the presentations, they diverge based strictly on timeline and topography. Dry AMD, gradual and insidious timeline. drusen deposits on the topography, mild blurring on exam, and managed strictly with antioxidants and smoking cessation. Wet AMD, rapid and acute timeline, subretinal hemorrhage or fluid, metamorphosia on exam, and it demands immediate intravitreal anti-VEGF. The crucial takeaway for you is this. Any acute visual distortion in a dry AMD patient strictly signals a catastrophic conversion to wet AMD.
All right, let's put these precise diagnostic rules to the test with a master case. This is all about deep integration. We're going to set up an exhaustive assessment that integrates a chronic ophthalmologic condition right alongside an acute, sight-threatening conversion.
Here is the structural blueprint you need to master. Imagine a 72-year-old smoker with a 5-year history of mild visual blurring. Suddenly, he presents with acute visual distortion in his right eye, explicitly stating that the straight door frames in his house look wavy. His intraocular pressures are normal, and his lenses are completely transparent. What is the immediate, most appropriate pharmacotherapy? You have to recognize that insidious background suddenly being disrupted by a massive topographic distortion.
Now, before we jump to the meds, let's systematically disarm the diagnostic traps embedded in this profile. The fact that he has normal intraocular pressure, that strictly rules out acute angle closure glaucoma, which would otherwise present with a rock-hard, red, agonizingly painful eye. Those completely transparent lenses, they strictly rule out cataracts. And the complaint about the wavy door frames, that is our absolute linchpin. It unequivocally marks metamorphopsia, isolating the true pathology as active fluid leakage.
So here is our exhaustive option matrix, with exactly 5 choices. We need to aggressively bypass the prophylactic and unrelated therapies. Option A, timolol drops. Incorrect. It's a beta blocker for glaucoma, and our patient has completely normal IOP. Option B, oral antioxidants. Incorrect. Sure, they're prophylactic for his 5-year history of dry AMD, but a vitamin absolutely fails to address the active hemorrhage destroying his sight right now. Option C, intravitreal bevacizumab. This is correct. An anti-VEGF inhibitor is the only acceptable rescue maneuver that directly halts the active neovascular surge causing his metamorphosia. Option D, acetozolamide. Incorrect. It reduces aqueous humor in glaucoma, totally irrelevant to a retinal hemorrhage. And option E, laser iridotomy. Incorrect. That's a surgical fix for closed-angle glaucoma and totally inappropriate here.
This kind of simulation demands absolute clinical precision. You simply cannot get distracted by prophylactic measures when active tissue hypoxia is triggering a hemorrhagic emergency. So, as we wrap up this explainer, I want to leave you with a critical challenge for your future practice. In a patient with chronic drusen, how quickly can you recognize the topographic distortion of metamorphopsia before the neovascular surge causes irreversible blindness? Stay sharp and stay vigilant.